Hi, I'm Stephanie Shelton, and this is Conversations on Health, How We Get There. At the core of any country's healthcare system are the nurses. Many are highly specialized, others keep hospitals and surgical centers functioning. And too often a nurse is the only one at a dying patient's bedside. I'm sure many of you are aware of the continuing nurses' strikes in the UK against their state-run healthcare system, as well as the recent one here in New York City. Yes, nurses want pay hikes, but the biggest issue is the continued understaffing of hospitals and other care facilities.
I applaud those nurses in the city for having struck because people think, oh, you're a nurse and you belong at the bedside and you shouldn't do something like that. And it's not about the money because
This is my friend Christine Dorn-Moldovan. She's a veteran nurse who now describes herself as a semi-retired substitute school nurse. But for much of her career, Christine was a staff nurse and then a nursing supervisor at two large New York hospitals. She also worked in the New York City public health system before moving on to school nursing. Now, Christine didn't start out to be a nurse, but after a few years working in Manhattan, she did some volunteer work at a hospital, and then she realized that nursing was a fit. She paid her way through a 3-year community college course, and she graduated with an RN. And I asked her if she still felt it was a good move after she plunged into the reality of nursing.
I did, because I love people, and I think there's no greater high that you can get in life other than helping another human being, especially when they're at the worst possible time in their lives. You know, you can hold somebody's hand, let them cry on your shoulder. It's very fulfilling that way.
That's one of the things I always thought about nursing, and have had enormous respect for people like you who have that ability, to help other people, and because there's a lot of dirty, unpleasant work. It's not all holding people's hands,
True.
But doesn't that wear kind of thin when you look at, for example, what's going on today, where there's a nursing shortage, it seems almost everywhere in many countries, where the nurses are saying they're not paid, they're not appreciated, there's not enough staff, they're stretched too thin. How do you retain that kind of sense?
It's difficult. It's difficult. It really has to come from within because you're exhausted. You can have a 40-bed unit with 2 RNs and 2 aides. And then what was happening, especially back then, and I'll equate it to now, back then, if they had sick calls, say I worked the night shift, and they had sick calls, they can demand that you stay. It's called mandatory overtime.
Whoa.
You could stay a half a shift, you could stay a full shift. Now, if you're a mom that's going home and has to get children off to school and your husband's going to work, it's very difficult. A lot of crying involved. Because what supervisors did, and I was guilty of it myself when I became a supervisor later on, is you can threaten that nurse with abandonment of patients, and that can go against their license.
Wow.
So it got very ugly early on. Where there was a waiting list for nurses in the 80s, all of a sudden by the 90s, people were abandoning it because of these things. So where I was fortunate in working for a union hospital in Queens, New York, St. John's and Far Rockaway, we were represented well by the 1199 union.
Yeah.
And what they fought for was to do away with mandatory overtime. Salaries were fine back then. They're even better now. But it was always about the mandatory overtime and the staff-patient ratios. And that carries through still to today.
Yeah, that's what I'm looking at, every time during the nurses' strikes in New York City, just the recent ones. Every time somebody on the picket line was interviewed, they'd say, yeah, the salary, we want more money, but what we really want is a guarantee that they're going to hire more staff.
Absolutely. Absolutely. And when you know that your hospital administrators are getting these great bonuses and things like that, it wears on you. You can't come in on Christmas Day with a box of cookies at the nurses' station and think it's going to make your nurses happy. It's not. You need more personnel. You do. You do.
But are there more, and are there more people who are going into nursing? Will there be more personnel? If you look at pre-COVID, post-COVID, it seems that I never heard of burnout in the sense that hordes of people would say the same thing. Yeah, one person would say, and I've had it, and that's one person, but everybody. I mean, look at the shortages post-COVID, how people have just, it isn't that they quit the hospital, they quit nursing.
Yeah, yeah, they were done. They were done. What was happening, and if I can reflect on what's going on with my daughter's a nurse, she also now has that love-hate relationship. And as an example, she was working in a hospital, it's a Mount Sinai on Long Island, in the endoscopy unit. So it was inpatient and outpatient. They closed the units when COVID was at its thing and switched all these nurses to the ICUs, the step downs. And she said there was one day where they wrapped 9 bodies that had passed away. And she would call me in tears. And this is what was happening to these nurses, that at the end of it, they were just like, done, just done. And we just was so woefully unprepared as a society for that. So they are leaving. They are.
And they're leaving, and at least, if you think of how long it takes to train a nurse, there really aren't people to hire.
No, unfortunately there's not. And I really think that they need to have more incentives. I know there is an issue with the government where they will give a stipend or forgive some student loans if a nurse is working in a socioeconomically depressed area. But it's not enough. The program has to be made better. Perhaps even use an incentive whereby, hey, if you go to community college, which you can still do and get your RN, I think in Jersey also, and definitely in New York, they haven't changed it, we won't even charge you to go. Maybe make it free tuition. I don't know. I don't know.
Well, certainly if we're really in trouble in terms of having enough nurses, then somebody needs to come along with a unique way of solving the problem. And the problem is that they're always looking back and saying, well, let's just solve it the way we always have solved it. And maybe post-COVID that you can't do that.
No.
When you look back, do you, I mean, you ended up quitting and going into, other than hospital nursing, school nursing, and you said you worked for a while for poison control.
Yes.
Why did you do that?
Well, what was happening is at that point, after being in the hospital for almost a little less than 2 decades, my kids were getting older. And I needed the freedom whereby if I had to take a day off, it wasn't detrimental to my coworkers. That was also an issue. So I thought, okay, I need to have a desk job, if you will. And I thought, okay, something challenging. So I found out about poison control. And also to backtrack, what was happening as a supervisor, I was also becoming responsible if nurses on my watch were making mistakes.
Oh.
And I thought, I just wasn't thrilled with the quality that I was seeing of the nurses. So I thought, I've got to do something, because my mantra has always been, I have a mortgage and I have a license and I need one to pay the other. So with this in the back of my head and being practical, I found the job at Poison Control, and I absolutely loved it because we were respected. We were certified in toxicology. Doctors were calling us for advice. Granted, it was a phone job, but it was such a wonderful experience.
What is the difference? And I truly don't understand, because when COVID hit, all of a sudden I found out we have a public health system as against a health system, which I always thought was just hospitals, doctors, whatever. What's the difference between a public health system and just going to the doctor the way you would normally go, or going into a regular hospital?
Well, the public health system doesn't worry about your insurance, doesn't worry about anything. You can go for the local, Sussex County in Jersey where I live has a health department, and they do women and child care. They'll do, exams, things like that. A lot of health departments will send the, I guess you call it a RV or a trailer out with mammography machines, and they go into the community, which is wonderful. I think as a nation that we should put more money into our public health systems, because they'll reach our people that tend not to go to doctors. You know, I think more clinics should be available. You know, great, it's nice that we have urgent care, but they also bill your insurance.
Yeah, yeah.
So
So the difference is that the public health basically is something in general that you as a patient would not pay for?
Correct.
And I know that, you know, they deal with the vaccines and all this kind of
Right.
thing, but
Right. So it's something that they need to pay more attention to. And they also needed to pay attention, going back to COVID, is listening to our public health professionals who was saying to them, hey, this is going to happen someday, and you need to be prepared, and you need to have different points, PODs, points of distributions, whereby that vaccines and supplies and PPEs, protective gear, will be available. And nobody listened.
no, Bill Gates was saying that and nobody listened, you know, so it wasn't just locally, it wasn't just at the state level. There were a lot of people who future gaze, basically, with big names saying it's going to happen. When you became a supervisor, did that change for you? You were talking about a responsibility, but you had, you know, in terms of, I imagine as a supervisor you had to schedule nurses, and you were essentially responsible for coverage.
Right. Absolutely. Absolutely. And that's when you became the bad guy, because if you had sick calls, I was a supervisor for the overnight shift in a 300+ bed hospital. So you were effectively the administrator on duty.
Right.
And you would have to schedule for the next shift. And that's when you would have to say to so-and-so, I'm sorry, we don't have any coverage, you'll have to stay. What then happened with, and it's unfortunate to say, but because I was union-based, it was better being in a union hospital, because the union fought and said to the hospital administrators, well, no, that's not working out. What you'll have to do is call in agency nurses to cover the shifts.
What's an agency nurse?
An agency nurse is, you would call an agency, an employment agency, if you will, for healthcare workers, and say to them, okay, we need either travel nurses or just a nurse to come in for this day, this shift. And you do have a lot of those nurses that'll do that, because it gives nurses who have families the freedom to say, oh, I'm not going to work today, I'll work tomorrow.
So it's like being a freelance nurse.
A freelance, thank you. Yeah, absolutely.
Interesting. I didn't know about that.
Yeah. And they get paid nicely. Yeah, travel nurses, yeah.
So I don't know if you've paid any attention to other countries that have mostly state-run healthcare systems, and also have what they call a public health system, but they're kind of more merged together. There's a lot of talk among academics mostly about how to make our system have better outcomes. We apparently spend more money than any other country in the world and have worse outcomes overall than many other states, or many other countries rather, that have state-run healthcare systems.
I blame what happened with our outcomes in the early, I don't know if it was late 80s, early 90s. The government decided to implement DRGs.
Which is?
Diagnostic related groups. You come to the hospital, you have a urinary tract infection, Stephanie's allowed 2.5 days of admit. Then she has to be discharged. So what became the mantra that was told to us was, discharge planning starts upon a patient's admission. Regardless if you had whatever else with it. So DRGs is a government program, and Medicare and Medicaid had to follow it, but then the insurance companies also picked up on it. And it was a way to say, okay, if this patient is not out in 2.5 allocated days that we've decided upon, we're not reimbursing you for that patient's stay. Then what happens on the other end of it is that the doctors got smart, and they would just add things to your diagnosis. Oh, Stephanie had a fever, that gives her another half a day. So it became this game where the system just became so convoluted and so wrong, instead of just relying on the fact that let's keep Stephanie in until she feels better. Now on the other end of it is, if they discharged you in the time that they expected you to be discharged in, and that urinary tract infection didn't clear up and you were back within so many days for the same diagnosis, the hospital would not get paid for your original stay. So the system is just so wrong and ridiculous.
So was that the period where if you went in to have a baby, they sent you home on the same day?
Absolutely. And I laugh now. It was unfortunate then, but it was I want to say, a New York State senator who was appalled at the fact that his wife unfortunately had to go in for a mastectomy. And then she was discharged within 2 days. And then all of a sudden they woke up and said, oh, wait, we have to fix this. Because if you remember years ago, if you went in to have a baby, you were in for about a week. If you had a cesarean section, 7 days.
Yeah.
And no, DRGs came in and said, mm-mm.
I remember I went in to visit a friend in the Czech Republic. This is, I don't know, maybe 4 or 5 years ago. And she just had her second kid. And there was a home maternity ward. And they keep them for about a week. They bring the baby in and let the mom and the baby kind of get to know each other
Right.
little by little, so the mom isn't overwhelmed. So it's interesting because what I'm hearing talking to you, and again, I come into this on a post-COVID, or during and post-COVID basis of what I know and what has bothered me about the whole thing. That a lot of this stuff has been around for a long time. The problems that just seem to have mushroomed after COVID were really there all the time in the system.
Right. And COVID just magnified it.
Yeah.
It really did. It really did. It became something that everybody in the country was aware of now. And finally nurses can say, we've been telling you,
Yeah.
But yeah.
But do you sense that although there was a lot of talk about what to do as COVID began to wind down, that things are just kind of, I mean, is this why the nurses struck in New York State?
Yeah.
That they really weren't doing anything?
Absolutely, because they made promises and promises and pacified everybody and gave little bonuses for having worked COVID hours. And I know my daughter got, an extra 1,000 or something at some point, the nurses did. And that was a way of saying, good job, thank you. But ultimately it comes down to where when you have too many patients, the patients suffer. Somebody's going to get the bedpan last.
Yeah.
Somebody's going to get their pain medicine last. And it's just it's unfortunate, and I applaud those nurses in the city for having struck, because people think, oh, you're a nurse and you belong at the bedside and you shouldn't do something like that. And it's not about the money, because I will tell you that having started nursing in the 80s, I remember my acceptance letter to the hospital made $21,500. Right? Put it in perspective. My daughter graduates a few years ago. The nurses that got hired in Manhattan was starting at $120,000.
Wow.
It's not no, it's not the money. It's not the money. The money, it's the staff-patient ratio. It's the danger of something happening that is your malpractice insurance. And it's
One of the nurses was quoted as saying, if people are stretched too thin and nobody is really watching the patients and something happens, I'm in danger of losing my license.
Yes, I always said that. In fact, I remember saying as a supervisor to patients, to families, this is the rainy day you saved for. We're stretched thin with staff. If you can hire a private duty nurse for the overnight, if you can stay at the bedside overnight and just be an extra set of eyes, that would be wonderful. And that's how it was, because you can only be so many places at once as a nurse.
So if you were dictator for a couple of months.
Oh, please. You and I?
Yeah, you and me too. But if you were, and they said, okay, here is our so-called health system. In terms of nursing, what would be the first things you would do?
Make nurses administrators of all hospitals. Stop bonuses. Can we talk about big pharma or
Yeah, you can talk about anything you want.
Outlaw.
I have no sponsors.
I love it. Outlaw the lobbying from big pharma to our politicians. Get the prices of drugs down. It's ridiculous. It's ridiculous.
In reality, that's probably never going to
Happen. I know.
with any industry.
I know.
But yeah, it would be nice. Okay, so what else? What would be the biggest thing, do you think, that could be changed that would encourage more people to go back into or to go into nursing so that we wouldn't have these staff problems?
I think besides forgiving some of the student loans or offering a free educational process or partial educational process to someone that wants to become a nurse is just the staff-patient ratios. The staff-patient ratios. I know that you get different views on 8-hour shifts. Some nurses like 10-hour shifts. Some like to work 12-hour shifts. I know that that's an issue that's been popular, the 12-hour shifts, because that nurse says, well, if I'm going to work, I might as well just stay and work the 12 hours and then be off 4 days a week.
Yeah.
So that's helped. That has helped. But yeah, at this point, I don't know what. I think what we need to do is encourage more nurses to go for the nurse practitioner and maybe get into the underserved communities.
What exactly is a nurse practitioner?
A nurse practitioner goes for extra years of education, sits for boards. She's an RN, and then sits for additional boards for nurse practitioner. And then she can be an independent practitioner. She can write scripts, she can see patients. A lot of doctors will have a nurse practitioner in their practice,
Right.
just to alleviate not having to have another doctor, or if they need it. Nurse practitioners are allowed, they can have a clinic setting, see patients. So they're much more highly skilled. I don't want to say highly skilled. They're much more educated than an RN would be, and they have the ability to write prescriptions, order lab tests, order diagnostics, that kind of thing.
It seemed to me that that kind of thinking would help a lot in rural settings where there mostly aren't hospitals even, certainly not enough doctors, and maybe people with families would want to go into something like that, you know, so that they could still have the better part of rural life, but they could earn a living.
I agree. I had a friend that after nursing school, she went down to Appalachia for about 2 years. And boy, it was an eye-opener. And she worked with a nurse practitioner down there. And she said, you get a great education because you see everything.
Yeah.
You see everything, but you feel like you're doing so much good because it's miles before these people can get to a health clinic or something. So yeah, I think there should be more encouragement of NPs.
I think you were also talking about that under the public health system, under the state aegis, more outreach into ill-served communities, because in the end, our outcomes are dragged down by people who never have a regular doctor and don't go for help until it maybe is either very expensive to treat them or too late. So if we could get into that segment of society, and it isn't always the poor, it's just people who don't go to doctors.
Well, I think it's also, yeah, you're absolutely right. It's not just the poor. It's also a cultural thing.
Yeah.
Where there's a mistrust of an authority figure or a doctor or something like that. So I think.
And isn't that a place where a nurse practitioner who isn't a doctor, with that elevated sense, you know, that some of us still have about doctors, but the nurse always has seemed to be a nurse, and I deal with a nurse practitioner, and she's extremely approachable, and I can ask her anything. And wouldn't that help?
I absolutely agree. I do. I think also that it would be advantageous because I'm finding, or I've found in my career, that a lot of communication exists where people are going to different doctors and nobody's talking to each other.
Right.
So there's a lot of confusion, and I always said that, for instance, I have a neurologist out of Cornell. She's wonderful. She also happens to be a PharmD. She got a pharmacology degree first and then went into neurology. So I think I'm getting a lot of bang for my buck, because here's a woman, a doctor, if you will, that will know the medication, know the side effects, know what they're doing. And I thought it would be great if every practice had like a pharmacist that's on there. And it's
So we're talking creative now, even in terms of education, to start mixing some of these things so that people who have primary knowledge in one area also have a little more around the edges.
Exactly.
For example, my internist, my GP, as I still tend to call them, my primary care doctor, started out as just a cardiologist. And then I think somewhere along the line he realized he could make more money if he was also an internist.
Okay.
So he took the extra training and got the additional degree. So he does both. And it makes him extremely valuable to you as when you go in for your normal exam. If there is beginning to be something wrong that has something to do with cardiology, you have that extra level. But he's approachable on the GP level.
Perfect. I want his name.
But if that was encouraged at the university level, if it was encouraged at the hospital level even.
I remember years ago, and she's still practicing, she's an infection control NP, a colleague of mine. The hospital board decided to award a nurse a an advanced degree to Columbia University. And she went and she got her NP, and she's still in practice. And I thought, wow, if that was more common. I mean, right now, from what I understand, in my day, you can get, if you went to a hospital and you wanted to further your education, they would give you $1,500 a year towards your tuition reimbursement. You'd have to get a certain grade or better, and then you would get that. I think if that was increased, phenomenal, phenomenal.
All right, so a final question then. We kind of skirted around all the issues. I come back again to this issue of of public versus private, and the idea that you really need a hybrid system, perhaps. If we could find some combination of that really meshed and make it one system, would that help?
I think so. I don't know if I could speak intelligently on it. I think so.
Well, you've worked on both ends of it. You worked for essentially the private part of the system, the hospitals and stuff, and the public part of the system.
Here's my hesitation in saying, as an American, because we're a country that was founded based on freedom. So I don't know how well our fellow Americans would go for being forced into something where they don't have a choice. That's my thought process. Yeah, I don't.
Well, it's a question that a lot of people ask. There is some choice built into some of these systems, and there isn't in others. I think in the UK you're somewhat stuck with where you are, where you live. It's not necessarily true in the Czech Republic, because they work with an insurance system, which is quasi-public, quasi-private. But they allow you to move around. So I don't know. I mean, there are a lot of I don't knows, just like you said. But if there were maybe some choice built into it,
it might be able to work.
The difference being that if there's a public system where you pay taxes into the system, everybody does, your employer does, poor are taken care of as they are now, that you don't have to worry if you lose your job that you're not going to have health care.
You're right. There should be some kind of like bridge. A bridge kind of plan that the government could supply to you, or however you can work it out. I know with the ACA, the Affordable Care Act, with Obamacare, in theory it was great. I know I have a son who graduated and then aged out of my husband's benefits and had to go and was employed, but then a few years ago, employers weren't giving you benefits. So he had to enlist in the ACA.
Yeah.
But that has problems because he had a $4,000 a year deductible.
Cool.
So yeah, there has to be some kind of bridge plan whereby if you don't have Medicare, you don't have Medicaid, and you're not insured by an employer, or you lose your job for so many months, that you can have that.
Yeah, that's a great idea.
Yeah.
Okay, I vote for you, dictator. Dictator for, I don't know, I'll give you a year.
Oh, okay.
Good
thanks.
luck. Christine, thank you.
Thank you, and thank you for doing this.
I usually
Wonderful.
ask my interviewees, which I should have done previously, but is there anything else that you yourself wanted to talk about?
I think I'm grateful that nursing is still considered one of the most trusted professions in the country. I'm proud of 95% of the nurses that I meet. I'm thrilled that my daughter has chosen it. It's interesting on her end of it that she's a visiting nurse for NYU now, and she gets to see how sick the patients are that are discharged. So yeah, we do have work to do. We do.
Okay. Thanks, Christine.
Thank you. Thanks, Stephanie.
My friend and now semi-retired school nurse, Christine Dorn-Moldovan, on the nursing profession and what she'd like to see changed or modified in the U.S. healthcare system after her years as part of it. Now, in the next episode, look for more about what we call the public health system and how it meshes or doesn't with the rest of healthcare in the U.S. I'm scheduling one new podcast episode a month, so look for that next one in mid-March. The drop day is usually a Tuesday. Updates wherever you get your podcasts, and please do subscribe. We're on Apple, Google, Spotify, TuneIn, iHeart, Podchaser, and my host platform, the Podbeam app. The video version is on YouTube. I'm Stephanie Shelton, and until I see you again, please take care of yourself and the ones you love. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.